terms that you should know. First one is ventilation. This is inspiration and expiration, basically active breathing, breathing in and breathing out. Now, hypercapnia, this one is the one to know. Increased CO2 levels in the blood with increased rate and depth of respirations. So the big memory trick here, just look at the C's. Hypercapnia, think high CO2, basically a PaCO2 above 45. The key number there is above 45. Clients can slip into respiratory failure, what's called hypercapnic respiratory failure, with too much CO2 inside the blood, which we cover in detail in the acid-base lectures. Now on the other side of the coin here, hypocapnia, those low CO2 levels. This may be caused by hyperventilation, basically blowing off too much CO2. Eventually it pushes the body into respiratory alkalosis, that base state, which again we cover in detail in the acid-base lectures. But real quick, just think here. Hyperventilation, we're breathing too fast, right? We're basically panting like a dog. Ha, ha, ha. So just think alkalosis for respiratory alkalosis. Any client with hyperventilation, they're going to breathe off all that CO2, which I call carbon dioxide, because it makes the body more acidic. So when you're breathing off that CO2, it leaves the body in that alkalotic or base state, because all that acid is alkalosis, putting the body into respiratory alkalosis. Now the next key term is gas exchange. So exchange of gas, that CO2 out and that O2 or oxygen in. Now this is done between the alveolar air and blood, those little capillaries inside the lung. Now lastly is hypoxemia, decreased oxygen in the blood. The key number to know is PaO2 less than 80 millimeters of mercury. 80 is the key number. Now lastly, another key term here is hypoxic drive in patients with chronic lung disease like COPD. Hypoxic drive is a form of respiratory drive in which the body uses oxygen receptors instead of carbon dioxide receptors to regulate the respiratory cycle. So let's review the key manifestations of hypoxemia. Also called hypoxemia. This happens when our PaO2 is less than 80 millimeters of mercury. That's a huge key number, so please write that one down. The earliest signs of hypoxemia affect the brain. Specifically, key term here, mental status change. Huge NCLEX tip. We typically see restlessness, agitation, also called irritability, as well as confusion. Now write these key terms down since they're highly tested. They are early signs and early detection saves lives. So these key terms are typical for any low oxygen in the brain, from a CVA stroke to increased ICP. So these key points came up a lot on multiple different sections, specifically in the neurological section of MedSurg or adult health. Always NCLEX favorites. Now for other signs here, the vital signs will be high. So respiratory rate, known as tachypnea, over 20 respirations per minute. The heart rate will be high with tachycardia, over 100 beats per minute. And the blood pressure, known as hypertension, over key term 140 systolic, that first number on the BP machine. Now, as the body scrambles for oxygen, it tries to move the little oxygen it has around the body. And that's why all the vital signs are high, as the body desperately tries to push around this oxygen. We'll also see our patient positioning with accessory muscle use, paradoxical breathing, as well as tripoding, where the patient's leaning over and trying to get their oxygen. And very late signs, we have low vital signs as the body fails to compensate. So we have low respiratory rate, known as bradypnea, bradycardia, that low heart rate, as well as hypotension. Now another late sign is skin that turns blue. This is called cyanosis. And one of the latest signs is ECG dysrhythmias, or basically funky heart rhythms, as the heart lacks oxygen. Now for O2 delivery devices, the biggest caution is to avoid combustion.
Oxygen is highly flammable, so keeping your patient from blowing up is a good thing. So the big no-no list on the NCLEX and most nursing exams. Number 1, no smoking. This open flame can combust in combination with oxygen. And no static, so synthetic or wool fabrics are a big no-no. Only cotton. And no flammable material like alcohol or even acetone inside of nail polish. We're talking a big risk for explosions here. So keep your patient safe and free from blowing up. Okay, now finally, for the big list of oxygen delivery equipment, I recommend focusing on the reasons why they are used, and don't get hung up on the percentages here directly, since it's not highly tested. And a little side note here, many textbooks vary on their numbers in terms of percentages. So our numbers were taken from 3 different textbooks, the Davis textbook and cross-referenced with Bruner and Iggy MedSurg nursing texts. So starting with number 1, NC, nasal cannula. The description is 1 to 6 liters per minute, and it delivers 25 to 45% oxygen. Again, focus on the reason it's given. So write this down. Used for short-term use, like with low oxygen after surgery, big key term there, or for long-term use, which can really dry out mucous membranes in the nose. So we typically use humidification for that long-term use. Next, we have the face masks. So first up is the simple face mask, 6 to 10 liters per minute at 40 to 60% oxygen. Now this face mask is used in exchange with a partial rebreather and even non-rebreather. So for partial rebreather, that also gives 6 to 10 liters per minute at 35 to 60%. Now these guys look very similar to the non-rebreather, but really the key difference is the flutter valves on the sides. The partial rebreather does not have those, and the simple face mask doesn't have a reservoir bag. So the big head honcho here is the non-rebreather. The acronym is NRB. So it delivers 10 to 15 liters per minute and is used in medical emergencies. It delivers 60 to 100% of oxygen. So the key point to write down, focus on this. So it's used during carbon monoxide poisoning, since only high flow O2 at 15 liters per minute will help eliminate that carbon monoxide and treat the hypoxia here. Now, if the reservoir bag is fully deflated on inspiration, we simply increase the oxygen flow. Huge key terms, a lot of students get this wrong. So you must monitor the bag and the valves to ensure the bag is more than halfway full. Now don't let the NCLEX and don't let exams trick you here. Do not open the flutter valves. These valves should be closed to help more oxygen get in during inhalation. And don't tighten the face mask straps first if the reservoir bag is fully deflated. Tightening the mask helps reduce leaks directly, but doesn't necessarily increase the reservoir bag. So once again, if the bag is fully deflated on inspiration, just increase that oxygen flow. Next, we have the Venturi mask, 4 to 10 FiO2. Now, key term, this is the most precise oxygen delivery device. So the memory trick we use are the double V's here. V for Venturi mask, just think V for very accurate O2. Typically used for patients with unstable COPD who cannot tolerate changes in oxygen concentration from other devices. And lastly, we have a face tent. This is specifically used for facial trauma and burns, since it has high humidification. So just think of the double F's here. Face tent for face trauma. Now for the top missed exam question. A patient recovering from surgery in the postoperative area suddenly becomes confused. The pulse ox reading shows a drop from 98% to 90% on room air. What is the most appropriate intervention? Now just think here. The key term was post-op or newly post-op, recovering from surgery. Those are big key terms. We know that this short-term drop in oxygen saturation can be solved with a short-term solution. So the most appropriate intervention is that nasal cannula. Now switching gears to BiPAP. Typically this is the last line oxygen device before ET tube or endotracheal intubation. Most commonly used for clients with worsening COPD who have high levels of CO2 retention, leading to that respiratory acidosis due to that decreased gas exchange. So the BiPAP is that positive pressure machine that forcefully pushes air deep into the lungs, giving much needed oxygen while expelling CO2. Talk about forceful gas exchange, right? This is primarily used to prevent respiratory failure caused by low oxygen and high CO2, which is common for clients in worsening COPD. Now, some key terms that you should know for respiratory failure. We have two types. It's either from low oxygen, called hypoxemic respiratory failure, from that low O2, or from high CO2, called that hypercapnic respiratory failure, over 45 CO2. So just think hypercapnic is from high CO2. Now the priority here is for a BiPAP. So the memory trick we use, just think hypercap, give a BiPAP. Again, it's very common with clients in worsening COPD with that decreased gas exchange. Now, very lastly, we have intubation, as mentioned before, our endotracheal intubation. Now, this is the ultimate solution to keep the airway patent. So we stick a tube directly into the trachea to ventilate the client manually via a bag valve or a ventilator machine. Now, this is typically used during surgery to keep the airway open, or as a last line for clients with a compromised airway, like patients who code or allergic reaction. We get swelling in that throat region, which closes the trachea, and even patients who are post-thyroidectomy, where they get swelling near that trachea. Now, the big stuff to write down is the complications. So write down VAP, ventilator-associated pneumonia. Always a huge key point on many exams. So we have to key term, reposition the client side to side every 2 hours to help mobilize secretions. And another key point number 2 is oral care. We use chlorhexidine every 2 hours, typically followed by oral suctioning. And very lastly, you want to monitor for key signs. We have positive sputum culture, a fever, as well as a chest x-ray with, key term here, new infiltrates. All these three typically indicate infection and worsening VAP, leading to that ventilator-associated pneumonia. All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the study guides. And also feel free to share the love, share with a classmate, and even your instructor. See you guys in the next videos. Now for respiratory failure and ARDS. To make this super simple, let's cover some anatomy and physiology. As you know, the lungs kind of look like an apple tree, starting at the stump, extending into branches, and eventually into leaves where the apples are. In the same way, the lungs start with a stump, called the bronchi, extend to bronchioles, our branches, and finally end at the alveoli, which I call our apples, because this is where all the action happens. This is where gas exchange occurs. We breathe in oxygen and breathe out that CO2. So in respiratory failure, this happens when the capillaries, the little tiny blood vessels in the alveoli, cannot adequately exchange that CO2 for oxygen. And as you know, oxygen is the money of the body. So no money, no honey. No oxygen, your body goes broke and dies. Now, commonly, infection will cause these alveoli to become swollen, inflamed, and filled with mucus or fluid which blocks gas exchange. So we see clients come in with the common flu or even the coronavirus of 2020, which can sometimes, in severe cases, either progress into pneumonia or even deadly ARDS, that acute respiratory distress syndrome. So the pathophysiology for ARDS. So just use a memory trick here. ARDS, think hard alveoli. They become hard because of the capillaries around the alveoli become inflamed and fluid filled, creating sort of like a leaky barrier, which eventually fills up these little alveoli sacs like a sinking ship. This makes it impossible to get oxygen in and impossible to get CO2 out. Eventually, clients die from hypoxia if they are not on a ventilator early. So write this down. Impaired gas exchange is the priority nursing diagnosis on most exams and hence most highly tested. Clients are on a ventilator as long as it takes for the inflammation and fluid to resolve. Now for the causes. ARDS typically develops from some type of inflammation in the body, like from sepsis, that bloodborne infection that inflames the entire body, or respiratory inflammation, either from pneumonia, inhaled toxin, or even aspiration. Now, a unique cause, clients with acute pancreatitis are at high risk for developing ARDS. Now, this is highly tested on the NCLEX, so I would write this one down. A lot of students don't know this one, so listen close to the patho here. The pancreas is responsible for making enzymes, right? This helps to break down food in the digestive tract. Well, with acute pancreatitis, we have inflammation inside that pancreas, which can accidentally release active pancreatic enzymes and cytokines into the bloodstream. And once in the bloodstream, they get sucked back to the right side of the heart and then into the lungs. These little enzymes can cause severe inflammation inside the little alveoli, resulting in pulmonary edema, that fluid in the lungs, then pleural effusion, and then atelectasis, that collapsed alveoli, and eventually ARDS, those hard lungs. So again, write it down. Patients with acute pancreatitis are at high risk for developing ARDS. Now the priority intervention for ARDS, write this one down. Mechanical ventilation, specifically PEEP, that positive and expiratory pressure. Fancy words for a ventilator, which pushes positive pressure into the lungs to push open the alveoli and re-expand them, forcing gas exchange to occur by forcing these capillary beds on top of one another. Again, this is what's known as PEEP, but we cover this in more detail in our ventilator lectures. Now lastly, we can always turn the client frequently from prone position to other positions in order to move that fluid around. Now a little side note here. The NCLEX really doesn't test directly on detailed patho or even the phases of ARDS, so you don't have to memorize that. Boards typically focus on signs and symptoms and how the patient will die. So focus on those sections when we get there. Now, switching gears to ARF, acute respiratory failure. We have two types, either hypoxemic failure from low O2 or hypercapnic failure from high CO2. Now the key numbers to know is a PaO2 of 60 or less for oxygenation and a PaCO2 over 50. Now these life-threatening conditions result either from a ventilation problem or quality of oxygen perfusion problem, aka a VQ mismatch. Basically, ventilation or breath inadequacies, like from opiate overdose, we have low and slow respirations, or even a neurotrauma, which affects the brainstem that controls breathing, or even after surgery, or even chronic conditions like asthma. And on the other side, for the quality of perfusion problem, this is what happens when the body fails to provide sufficient oxygen into the blood. Like with heart failure, we have heavy fluid in the body, or even pneumonia, that infection in the lungs, even PE with a pulmonary embolism, that clot in the lungs. Or lastly, even COPD, chronic obstruction from that chronic destruction of the lungs. Now, whatever the condition, either ARDS or respiratory failure, the big key here is low oxygen. So in terms of signs and symptoms, write it down, hypoxia, that low O2. The first sign is altered mental status. Huge NCLEX tip. And the three key signs to write down and know by heart is agitation, restlessness, and confusion. So once again, write these three down. Exams and the NCLEX love to ask which clients should the nurse see first. If you see these words, agitation, restlessness, and confusion, you have to think oxygen issue. So trust me, this comes up a lot on priority-based questions for your exams and for boards. Now the key sign for ARDS, write this one down as well. Refractory hypoxemia. The key here is low PaO2 despite oxygen delivery. So the memory trick, just think the body is resistant to oxygen in refractory hypoxemia. So for example, a patient's O2 level drops from 95 to 90. So naturally, we're going to put some high flow oxygen via non-rebreather. But what if that oxygen level keeps on dropping into the 80s despite the oxygen delivery? Well, this is what happens in ARDS. Since ARDS, we have hard lungs, and that hard lung cannot exchange oxygen. Now, in terms of lab values, exams and boards love to ask about ABGs, the arterial blood gases. So write this down. We're looking for low PaO2 and high CO2. So when given the option for which ABG is the highest priority, it's very simple here. Always look for the lowest oxygen value first, since oxygen is the money of the body, and then look for the highest carbon dioxide value, that high CO2. So I'd recommend writing out this ABG chart at least 10 times the week of your exam because you must know these values. So a top miss question here. Which ABG values support suspected acute respiratory failure, that ARF? So again, look for the lowest O2. So it can't be 55, not 62. So option 3, 47 is our lowest O2. And then easily look for the highest CO2. So 63 in option 3 is the highest there. Now switching gears to interventions. In ARDS, as mentioned before, the only thing that's really going to help is that ventilator on PEEP. That positive pressure that pushes oxygen in to force gas exchange through that inflammation and the fluid, as well as rotating our client to move that fluid around. Now, for clients experiencing general respiratory distress, we call a rapid response. And first things first, you immediately raise the head of the bed. So use the acronym HOLY. Like, holy cow, this patient needs help. So H for high Fowler's position. Always, head of the bed is up. O for oral suctioning and oxygen. And then L is for listen to lung sounds. And lastly, Y is to yell for help. Or basically notify the HCP provider. Now write these down. A lot of exams love to ask which order these go in. So always position first, suction second, then oxygen, then assess lung sounds, and then lastly, notify the HCP. All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz. Asthma is a chronic inflammatory disorder in the major pathways of the lungs, the bronchi and the bronchioles. When these guys get inflamed, it's called bronchoconstriction, since the bronchi constrict down and get tight. Unlike COPD, which is irreversible, resulting from long-term chronic damage, mainly to the alveoli and bronchi, like from years of smoking or other inhaled toxins. Asthma is very different in that it comes and goes with flare-ups in the form of asthma attacks. Now, these are reversible. Another key difference is that only the bronchi are involved here and not the alveoli, and it typically does not cause long-term damage. So think of the double A's. A for asthma, A for acute attacks that can come and go, typically triggered by anything that can irritate those sensitive bronchi, like cigarette smoke, pollen, dust, strenuous activity, and even cold weather. But we'll talk about the triggers later in a moment. Whatever the cause, during the asthma attack, two key things happen. First, the bronchi puff up with inflammation and get very tight. Again, this is called bronchoconstriction. And secondly, the body secretes excessive mucus from the goblet cells that line the respiratory tract, resulting in wet, mucus-filled lungs. Now, this is super deadly since the respiratory tract gets so constricted, closing off any and all oxygen to the alveoli. This means no oxygen in, so we get decreased inhalation, and no CO2, that carbon dioxide, out, resulting in air trapping, making it hard to exhale. Now, this leads to acidosis in the body, which could lead to deadly respiratory failure. Now, in terms of the signs and symptoms, we use the acronym asthma. And a little tip here, focus on the highlighted ones below since these were the most tested out of 5 different exam question banks. So A is for accessory muscle use, due to the increased work of trying to breathe. And a key critical sign here is paradoxical breathing. Write that one down. It's very deadly. This indicates diaphragm muscle fatigue. And a little NCLEX tip here. Focus on the most deadly signs since these are the most tested signs. S is for shortness of breath and dyspnea, that difficulty breathing. And a critical sign here is single word dyspnea. T is for tight chest and tachypnea, that fast respiratory rate. So just think about it here. Air trapping in those inflamed lungs lead to tachypnea, a rapid respiratory rate. You're unable to take a full deep breath. H is for high-pitched wheezing, probably the most classic sign of an asthma attack. It sounds like a whistle, due to that inflammation causing narrowed airways, sounding a lot like this. M is for minimal diminished breath sounds. Now, this next part you need to write down. The key signs for deadly respiratory failure and deadly status asthmaticus, just think of the 3 A's here. So our first A is for absent breath sounds. This is known as a silent chest. Now, this is priority. Write this down. On exams and the boards, if your patient suddenly stops wheezing during an asthma attack, this is not a good sign. The NCLEX will not suddenly cure your patient for you, so exams won't give you a cured patient. This typically means that the lungs are puffed up so much and get so tight that it completely cuts off all oxygen and airflow, leading to the last 2 A's here. Acidosis, that CO2 retention, and air trapping. So we get prolonged exhalation. Write that down. Prolonged exhalation. Now, don't get tricked here. Not prolonged inhalation. We see the key term once again, prolonged exhalation, breathing out. So just think of the patho here. We have inflamed lungs, right? So we can't get oxygen in. We have short inhalation, not prolonged. And you can't get CO2, that carbon dioxide, out. So the key term, prolonged or longer exhalation, that air exiting the body. So in result, CO2 builds up in the body, causing acidosis from that carbon diacid, that carbon dioxide. Now for a big patho test tip for your pathophysiology on acid-base imbalances during acute asthma attacks. So please be sure to write this down. Many exam questions love to ask about the early stages and late stages of acute asthma attacks. So for early stages, we see respiratory alkalosis from hyperventilation. The client is breathing off too much CO2, that carbon dioxide, right? So the memory trick, just think of panting like a dog from hyperventilation. Breathing out all that CO2 or that carbon dioxide, the client will be in alkalosis. So they're going to be breathing off that CO2, which pushes them into an alkalotic state. Now for late signs, after the client is exhausted from too much breathing or hyperventilation, they're going to progress into respiratory acidosis. So eventually, as the client tires out, the respirations become slower and slower, leading to this respiratory acidosis from the CO2 retention. So hypoventilation from retaining too much CO2. So the memory trick, just think of someone snoring with low and slow breathing. It kind of sounds like respiratory acidosis as someone snores. So again, just think low and slow breathing, we retain a lot of CO2, that carbon dioxide. Now for the critical complications. If this carbon dioxide gets too high, it can lead to hypercapnic respiratory failure. We're just talking high CO2. The key term here is respiratory failure from that high carbon dioxide. Basically, we have an acid crisis. So let the name help you here. Just think hypercapnic as high carbon dioxide, resulting in high acid that pushes the body into that acidotic state from carbon dioxide. So once again, the memory trick, just think carbon diacid for carbon dioxide. It makes the body an acidotic state. Now, this results in acid crisis, which shuts down the lungs. So the key numbers to know for ABGs, those arterial blood gases, is number 1, a pH less than 7.35. This indicates acidosis. A PaCO2 over 45 is acidosis, and a PaO2 less than 80 is hypoxic. Now, the first sign of hypoxia is that mental status change. Now, this goes for any condition. So the ones to know, there are 3 of them. First is agitation. Second is restlessness, and then drowsiness. So once again, if you're talking neuro, respiratory, any condition on the NCLEX, you have to know these 3 signs as the earliest sign of hypoxia. Lastly, as mentioned before, status asthmaticus is a medical emergency. It's an asthma attack that will not resolve with medication. Basically, the patient gets stuck in this asthma attack. We're talking inflammation so severe that no airflow is possible, and the client dies. So the priority intervention in any critical complication is number 1, an endotracheal tube or endotracheal intubation. So write that down. Again, typically the most deadly key points are the most tested key points. Now for another patho side note. A key sign of status asthmaticus is pulsus paradoxus. Big test tip here, so be sure to write this down. We see a drop in systolic blood pressure more than 10 millimeters of mercury. Now this is a huge indicator of the asthmatic emergency, status asthmaticus. Pulsus paradoxus is when the blood pressure decreases by that 10 millimeters of mercury during inhalation and then increases during exhalation. You see, asthma increases that negative pressure within the lungs, and this puts a lot of added pressure on the heart, particularly the left ventricle, which is the part of the heart responsible for pumping out all the oxygen-rich blood to the body. So this pressure on the heart causes pulsus paradoxus. Now, the 3 items that pulsus paradoxus includes is number 1, a decrease in stroke volume. And stroke volume, again, is how much blood comes out of the ventricles with each pump, which makes sense since the heart is being squeezed here, so naturally we're going to see a decrease in stroke volume. And number 2, we see a decrease in systolic blood pressure, which is the number on top of a blood pressure number. Now, I call this the systolic squeeze, as it measures the amount of force being pushed out of the heart and to the blood vessels after each heart pump. So naturally, with the heart that's being squeezed down here, we get a less forceful pump with less pressure coming out of the heart. So basically, less systolic pressure, that systolic squeeze. And finally, number 3 is pulse wave amplitude during inspiration. As you know, during normal breathing, there is a fall in pressure less than 10 millimeters of mercury. Now, this is natural and to be expected. But once again, when the drop is more than 10, then this is referred to as pulsus paradoxus. So be sure to write that number down, a drop in systolic blood pressure more than 10. Now, switching gears to diagnostics, we can use a pulmonary function test, also called a PFT, but this was not really tested on directly, so I would not focus on this. Now, teaching, I would focus on the peak expiratory flow rate. Now, this is used to take a peek at the client's peak air flow, sort of like a weather forecast. We want to anticipate a severe asthma attack before it happens. So the device we use is called a peak flow meter. This device measures peak airflow to see how tight the airway is before symptoms get worse. So it kind of works like a traffic light. We have 3 zones: green, yellow, and red. For the green zone, just think green means go. Asthma is around 80 to 100% under control. There should be no worsening symptoms, so no further medication is needed. Now, the next one, write this down, is the yellow zone. Yellow, think mellow. Asthma is not under control here. There's a huge need for additional medication. So once again, the memory trick. If the score is yellow, we need to mellow out that asthma with additional medication. So write down these key points. Number 1, a rescue drug is used every 4 hours for 1 to 2 days. And number 2, we have to call the HCP provider because we need additional medications or a change in the treatment. Now write that down. The NCLEX will try and trick you here. Patients must follow up with their primary provider even if they return to the green zone after taking the rescue meds. Now, most students get this wrong on various question banks. Remember, yellow is a warning sign here. We need to mellow out that asthma with additional meds. Lastly, we have the red zone. Now, red, just think really bad. Emergency treatment is needed immediately if the level does not return to yellow right after taking those rescue drugs. Now, switching gears to the correct order of how to use a peak flow meter. Number 1, we stand or sit in upright position. Number 2, put the flow meter scale to 0 or the lowest value. Number 3, you inhale deeply and then put the mouthpiece in the mouth and create a seal with the lips. Now, number 5, write this down. Exhale as quickly and forcibly as possible and record the reading. Then number 6, repeat 2 more times with a break of 5 to 10 seconds in between. And then lastly, write this one down. Record 1 score, which is the highest score of the 3 attempts. Now write down the highlighted key points here. Many students get these 2 wrong on various question banks. And don't let the NCLEX trick you here. We take 3 attempts. We do not average the 3 attempts. So the key point is that we do it 3 times, but we only record 1 score of the day, which is the highest score. And lastly, don't let the NCLEX trick you again. A personal best score is obtained over a 2-week period when asthma is controlled, and not from a daily reading or a daily best score. Okay, now as far as teaching triggers, just think of the A's and the S's for asthma. A for allergens like dander, dust, and pollen, as well as elevated eosinophils, which is a blood test that indicates an asthma attack was triggered by an allergic reaction. So write that down. This one came up a few times on various question banks. Now don't get tricked. It was eosinophils, which indicates allergies, not neutrophils and not lymphocytes, which indicates blood cancer and infection. So the memory trick, just think eosinophils as ew, nasty allergies. Having a lot of gross mucus just dripping everywhere, like eosinophils. Okay, next is the S's. So S is for smoking, even secondhand cigarette smoke, and S for stress, from emotional or even physical. Now Kaplan states, further teaching is needed when which statement is made? And the correct answer, stress does not cause my asthma attacks. Yes, this needs further teaching since we know that stress does actually cause asthma attacks. And the last 3 S's here. S for sickness, like influenza or even a URI, that upper respiratory tract infection. S for severe weather, especially in the cold. And the last one's a little bit tricky here. S for strenuous activity. There's no need to avoid exercise. So just take the meds before exercise, and this is a tricky one again. Many students get this wrong, so listen up. Patients do not need to avoid physical activity altogether. We simply instruct the patient to take meds 20 to 30 minutes before the exercise to prevent that exercise-induced attack. And secondly, don't get tricked here. Latex does not trigger an asthma attack, and neither does antibiotics like cephalosporins or even penicillin. These guys cause other allergic reactions, but not an asthma attack specifically. Many students chose this on a few different question banks and got this wrong.
All right, hold your horses. Here's another patho side note. You should know the two different terms that revolve around asthma flare-ups. We have extrinsic and intrinsic factors here. So starting with extrinsic, just think external. This occurs in response to allergens that are outside of the body. Basically external for extrinsic. For example, pollen, dust mites, and even mold, like we mentioned before. It is classified as a type 1 immune reaction, or a type 1 hypersensitivity reaction, with an immediate allergic reaction, where an allergen enters the lungs and the antigen combines with an IgE antibody on the surface of pulmonary mast cells that line the lung tissue, or pulmonary epithelium to be all fancy. Now, the key point here is, remember, mast cells are responsible for massive inflammation in response to allergies, contributing to chronic airway inflammation response when overactivated. Now, switching gears to intrinsic or internal factors here. This asthma is typically triggered by something inside the body and not by allergens outside the body. So some refer to this as non-allergic asthma. So please be sure to write this down. Asthma hyperresponsiveness, which is typically adult onset. These asthma attacks are brought on by the 4 S's. So S for sickness, like a respiratory infection. Once again, just think intrinsic. This infection is inside the body. And S for stress inside the body. The third S is for severe weather, like cold. Okay, now this one is technically outside the body, but you kind of get the idea here. It's not technically an allergen. Now, the fourth S is for strenuous activity and that exercise, which once again is brought on by self. And lastly, another outside factor are drugs. There are certain over-the-counter and prescribed drugs that are known to trigger asthma. So let's cover those right now.
Now, speaking of drugs, the two to know that can cause an asthma flare-up. So N for NSAIDs, just think N for not good for asthma. And to help you remember all the names for NSAIDs, we made the nifty acronym NSEC. Now, from this list, just focus on naproxen and ketorolac. These are typically used most often on the NCLEX and exit exams, so recommend pausing your screen and writing these down. Next, we have B for beta blockers, which puts the brakes on the heart, ending in LOL, like propranolol. Just think B for it blocks the heart rate and the lungs. Beta blockers block beta 1, so just think one heart is blocked. And it can also block beta 2, so think 2 lungs are blocked. But only if it's non-selective, like propranolol, brand name Endurol. This is non-selective, so basically meaning that both the lungs and the heart are blocked. Now on the other side, atenolol is selective. It's called cardio beta 1 selective. So it selects only the heart to block and does not block the lungs or impact the respiratory rate. Now in terms of pharmacology, we have an entire series in our respiratory pharmacology master course, but we'll do a quick recap here. Now we have 2 teams, the bronchodilator BAM team and the anti-inflammatory SLAM team. Now I recommend focusing on the bronchodilators and the S in SLAM for steroids. These are typically the most tested. So starting with bronchodilators, B is for beta 2 agonist, and the drug to know is albuterol. So just think we give buterols for brutal asthma attacks. And it's considered the one and only rescue drug for asthma attacks. We always give buterols first before any and all drugs during an asthma attack. So that's why we put it here first on the list. Now A is for anticholinergics, and ipratropium is the drug to know. Now this dries out the body, decreasing secretions and dilating the airways. So just think the dry here. You can't pee with a tropium. And M is for methylxanthines, ending in phylin like theophylline. So just think it's very toxic and a very fast heart rate. And the therapeutic range to know is 10 to 20. So the memory trick we use, think fill-ins have you fill in toxic and tachycardic. So Kaplan mentions aminophilin or aminophilin is a bronchodilator. And Hesse mentions the therapeutic range for theophylline is 10 to 20. Now on the other side, think of the SLAM team for anti-inflammatory agents. We have S for steroids ending in zone like beclomethasone. And the top side effects to know, just think of the 3 S's for zone ending steroids. We have S for sores in the mouth. This is known as oral thrush. So instruct the clients to wash their mouth out after every use. And think steroid inhalers go right into the sink at least twice per week. The next S is for sepsis and sickness, since steroids increase the risk for infection, increasing the WBC count inside the body. And the last S is for sugars that are increased. Now, these are completely normal, so we have to watch out for these. Now, the last 2, which are not highly tested here, so I wouldn't focus on them too much. We have L for leukotriene inhibitors, ending in Lucast, like Montelukast. Now, the brand name is singular, so just think Luke likes to sing. And M is for mast cell stabilizers, like Cromolyn. But again, it's not highly tested, so I wouldn't focus on these too much. Now, switching gears to meter dose inhaler teaching. ATI mentions a client should hold their breath for 10 seconds after inhaling so that the medication can get into the deep airways. And Kaplan mentions a need for further teaching when a client states, "I will be careful not to shake the canister before using it." No, we need to shake the canister, so further teaching is needed here. All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the study guides.
Okay, now for the case study on asthma. Miss C is a 25-year-old who presents to the emergency department with reports of dyspnea after going on a jog. She was diagnosed with asthma at age 10, but it has not caused any serious medical issues until now. She is diagnosed with an acute asthma attack. Okay, those are a lot of key terms here. Always consider the key terms before looking at what the question's asking for. So this looks like exercise-induced asthma attack. So question 1, which assessments are critical for the nurse to perform first? So once again, look at the key terms. This question's asking for critical assessments to perform first. So this is a priority question. Always think what kills the patient the fastest. In this case, the client was diagnosed with an acute asthma attack. Oh, snap! Think of the patho here. Inflated lungs and increased secretions, cutting off oxygen into the lungs. So we must assess ABCs, that airway, breathing, which is huge for inflated lungs post-attack, and then circulation. So the correct answer is oxygen saturation, respiratory rate and pattern, and breath sounds. Yes, we always want to monitor these clients the closest so that they do not slip into another asthma attack, and you can intervene immediately. Now, moving in deeper into the case study, the assessment comes back with this data. Oxygen saturation is at 87% on room air. The respiratory rate is 34, and expiratory wheezing is noted upon auscultation. Oh, snapperoonie. So that oxygen saturation is very low. Remember, O2 sat that is normal is 95 to 100%. And the respiratory rate is high, normally between 12 and 20. And the big key term here is expiratory wheezing. This could indicate another asthma attack is on its way. Okay, now for the question. Question number 2, based on the assessment data and the client's history, how would the nurse classify this client's asthma? Okay, let's look at the key points in the question. The client's 25. She reports dyspnea, that shortness of breath, after jogging, that light run, and asthma attack history from 10 years old. So this would be classified as adult onset intrinsic brought on by exercise. Now, I know that the client was diagnosed at 10 years old, but the current attack happened at 25 years old. So now she's an adult. Now, question 3. What are two pathophysiological processes responsible for signs and symptoms or manifestations noted during an acute asthma attack? So the two underlying pathoprocesses, remember the two from the full video. So number 1, we have bronchoconstriction, that airway inflammation. And number 2 is mucus production. Now, if you didn't know these, please be sure to write them down and know them for exams. Now, question 4, which additional assessment data does the nurse anticipate? Now, the key term, additional assessment data. This means additional signs and symptoms or manifestations. Basically, how will the client present? So remember, think of the patho first. Airway inflammation and mucus production, right? So the correct options, chest tightness from that bronchoconstriction and a cough from that mucus. Now, moving on to question number 5. What is pulsus paradoxus and what does it indicate? So remember the big test tip from the full video. Pulsus paradoxus is P for priority. Pulsus paradoxus is an indicator of asthmatic emergency, status asthmaticus. Pulsus paradoxus is when the blood pressure decreases by at least, key number here, 10 millimeters of mercury during inhalation and increases during exhalation. So please be sure to pause the screen and write down that key term, 10 millimeters of mercury for blood pressure that decreases here. Now, question 6. What is the pathophysiology behind respiratory alkalosis that is observed during the initial stages of an acute asthma attack? So once again, recall the key points from the full video. During asthma attacks, we see 2 stages here. Early stage is marked by fast breathing, that hyperventilation. Clients are panting like a dog, pushing them into alkalosis. The help from memory trick sounds like a dog panting, right? Blowing off all that CO2, that carbon dioxide, which I call carbon diacid, because carbon dioxide pushes the body into acidosis. Therefore, without CO2 as the body's breathing it off, the body becomes alkalytic, pushing the body into this alkalotic state. So the correct answer here is initially the client will experience respiratory alkalosis during the acute asthma attack due to the hyperventilation and excess CO2 removal. Eventually, as the client tires out, respirations will become slower and shallow, leading to respiratory acidosis due to that CO2 retention. So yes, don't let exams trick you here. Early stages, we see respiratory alkalosis, and late stages, respiratory acidosis, as the client gets tired and retains all that carbon diacid, that carbon dioxide. And breathing would be priority. Now moving on to question number 2. The nurse is interpreting an ABG result for a client currently being treated for an acute asthma attack. The result is as follows: a pH of 7.55, a PaCO2 of 28, and a 23 HCO3. What is the best explanation for this acid-base imbalance? So again, pause the screen and try your best to answer this question in about 60 seconds or less. Okay, let's break it down. This one is a big mama ABG question. But first, let's break down the key terms. The client is currently being treated for an acute asthma attack. So we expect the client to be in respiratory alkalosis in the early initial stages of the asthma attack from that hyperventilation, as you can see from our memory trick right here. Now let's break down the ABG numbers just to make sure. So let's use our marching band suit method from the ABG video. So step number 1, pH. Remember, P for pH is P for primary. So pH is 7.55, so it's base in the alkalosis area. Now step 2, we have to find the base match here. So PaCO2 is 28 in the base area, so this is a match with our pH. And bicarb HCO3 is 23. It's closer to the acid area, but is technically in normal range. So two bases make a match for alkalosis. And the lung icon tells us it's respiratory alkalosis, since the match is in the lung area. So the answer here is respiratory alkalosis. Woohoo! But this is only part of the answer here. The question's asking for the best explanation for acid-base imbalance. Well, it's hyperventilation, of course, as mentioned before. So option A and B are incorrect because it says respiratory acidosis. We're looking for respiratory alkalosis here. Now option C is incorrect. Respiratory alkalosis due to slow and shallow breathing. No, low and slow breathing would be acidosis, like snoring. That acidosis. Retaining all that CO2, that carbon dioxide, that we call carbon diacid. So keeping that carbon diacid in the body makes the body acidotic, or basically pushes the body into acidosis. Now option D is the most correct. Respiratory alkalosis due to hyperventilation. Yes, this must be true. Hyperventilation in the early stages of that asthma attack. Now lastly, question number 3. The nurse is assessing a client who's experiencing an acute asthma attack. Wheezes are heard upon exhalation. What is the best explanation for this assessment finding? So once again, pause the screen. You got 60 seconds. Now let's break it down. As usual, follow the question breakdown strategy. First, look for the key terms in the question. The client is currently experiencing an acute asthma attack. Wheezes are heard. The question is asking for the best explanation for assessment finding. So always think of a few things you know about those key terms. Think of the patho first here. With an asthma attack, we have bronchoconstriction, inflammation, and inflation within the bronchi, not allowing airflow, right? So this results in the wheezing whistle. So option A would be incorrect. Fluid buildup within the lung basis. No, there's no fluid buildup here in asthma. This will be true for heart failure, where we have heavy fluid. Now B is correct. Bronchoconstriction and airway inflammation. Yes, the key term here is bronchoconstriction and airway inflammation. This is correct patho. Now options C and D are incorrect. C says air trapping within the alveoli. No, this is more true of COPD, that chronic obstruction from chronic destruction of the alveoli. And D, thick mucus buildup within the bronchi. Now this is very close, but it's not the most accurate here. So yes, we do have mucus buildup, but this question's asking specifically for the best explanation for wheezing during that asthma attack. And that would be from that bronchoconstriction. So a big test tip here. If you ever doubt your answer, always reread the question and see what it's asking, and then choose the best answer choice.
All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the study guides. And also feel free to share the love, share with a classmate, and even your instructor. See you guys in the next videos.
And breathing would